speaking to the Colorado Strong Group once a year and updating us on a potential cure. I'm not going to say the word cure, but um, Dr. Harsh has been working on this since the late 90s. So we appreciate your dedication. And he's also going to speak for 10 minutes and then stop and we can ask any questions. And I just asked him to do this because in the past, when we have a speaker, it's hard to sit all the way through a meeting with narcolepsy. So if we have a little interruption where people can ask questions, then that's the whole point of speaking for 10 minutes. We'll ask questions and then he can go on with his presentation. So thank you, Dr. Harsh. We'll turn it over to you.
Great, Kristen. Great idea for me to talk for a little bit, maybe a little bit more than 10 minutes, and then have a discussion. And that's one of the things that I was thinking about when I was talking, putting this talk together. So what can I do that might, where we might benefit the most from a discussion interval? And reviewing some of the data that was presented at the meetings last year, the APSS meetings, I came up with a thought that maybe during that discussion period, we can talk about what you can do, or what a person that's affected by narcolepsy or hypersomnia can do to ensure that their own individual narcolepsy, idiopathic hypersomnia burden is understood and optimally managed. So in reviewing the existing data, it became clear to me that it's not always the case that what's being done in the clinic setting is what needs to be done. I find that patient burden is often not fully assessed, that comorbidities are sometimes taken as a part of the clinical history, but they're not fully evaluated, especially during the treatment. And I find that not all affected individuals, or even all healthcare providers are familiar with all the treatment options. And so I'm going to talk for a little bit, and then I would like to hear from you about what you think that you can do to be sure that your situation is being properly addressed, properly managed. So talk generally about narcolepsy with cataplexy, narcolepsy without cataplexy, and idiopathic hypersomnia. And some of the things that we know that are important in relation to what I want to focus on is that these are all rare and burdensome disorders with onset during critical years of growth and development. Diagnosis is delayed by misattribution of symptoms. I did a paper in the late 90s and found that the average age of onset for narcolepsy was like 15 and a half. The average age of diagnosis was 32. Okay, I mean, that's 17 years that patients on average were going without diagnosis and treatment. We're doing better now. We're doing a lot better, but still not there. At the point of diagnosis is 5 to 10 years after onset of symptoms. Still too long, still progress that needs to be made, but we have made some progress. We know that these are complex and varied disorders, heterogeneous disorders, that what we find with one person is not what we are likely to find with the next person. And that complicates our ability to diagnose and treat. And we know that comorbidities complicate the diagnostic picture and the treatment picture. So a major thesis is that for many affected individuals, burdensome disorders, patient burden is not fully recognized. Comorbidities are not carefully considered during evaluation and treatment. Treatment alternatives are not carefully considered because awareness of treatment options is limited. So what I'm going to focus on in this first part before we break for discussion is narcolepsy with cataplexy.
You can't hear this person.
And the reason I want to do that is that with narcolepsy with cataplexy, there is a group of 5, a pentad of symptoms that we all learn about starting from when we first are introduced to narcolepsy. That's sleepiness and cataplexy, hypnagogic hallucinations, sleep paralysis, and disturbed sleep. Now consider that if you are in a patient setting, or if you are affected by narcolepsy, and if this is the well-recognized pentad, then you assess your status with the disorder in terms of this pentad and the success of your treatment with regard to this pentad. And I don't think that's the way it should be. And to make that point, I'm going to talk about some of the abstracts that were presented at the APSS meetings. So here's one, a patient burden. So this is Anne-Marie Morse. Some of you may have heard her talk. And she asked about what insights we could get from physician notes about management of narcolepsy and idiopathic hypersomnia. She did a query of a huge patient database and identified patients with people with narcolepsy and IH, and she looked at the medical notes, and these are her conclusions. Okay, this is what's going on now from her perspective with what she has done. Physician notes, she looked at all these physician notes from all these cases. Physician notes inconsistently report symptoms, and inconsistently report evaluations and treatments. She found that social, family, and work factors, I know from talking to you all before, that these are all important, but were rarely reported in physician notes. That's important. If social, family, and work is compromised at evaluation, you start treatment, how do you know progress is fully being made without asking about these factors? So for full patient burden is unrecognized. Here is another one that I think that you'll like. This is from Kieran Maskey from Boston Children's Hospital. For those of you who follow the literature, this is an important contributor to the field also. She asked, what are the cognitive symptoms experienced with narcolepsy type 1, and what's the impact? You all know this. You all know about the cognitive symptoms, but what she reported in some detail is that almost all of the cases that in almost all the cases that she identified, there was reports of moderate to severe trouble remembering and difficulty with focus and sustained attention. Secondly, she reported that in many cases, there was no improvement in these symptoms in 2/3 of the cases. So this is the significant conclusion for Dr. Maskey. That symptom pentad, she says, is an incomplete representation of the clinical picture. There needs to be more, and that cognitive symptoms experienced by almost all affected individuals should be considered a core feature, okay? And it should be a core feature because this is something if it is a core feature and it's moderate to severe, that needs to be evaluated at follow-up during patient management. Shouldn't focus just on the pentad, should be focusing on the cognitive symptoms as well as other symptoms. So here is a topic on idiopathic hypersomnia and major depressive disorder. In about 50% of the cases of IH, we find major depressive disorder, okay? And the patients, IH patients with major depressive disorder and without major depressive disorder are different. Clinically, they're different. Their polysomnographic differences aren't that clear. But the interesting thing that caught my attention there is for this group of patients with and without, most common presenting symptoms were sleep inertia, only 50%. In my experience with idiopathic hypersomnia, most patients have significant sleep inertia. They can't get started in the morning. Non-refreshing naps was a problem for only 34%. In my experience, a lot more than that had problems with non-refreshing naps. And disrupted sleep in 25% of the cases. So attending to this comorbid condition is important because IH with major depressive disorders probably requires a different treatment strategy. With regard to treatment, we have a lot of treatments, but here is a study by a group from Stanford describing healthcare providers of patients with narcolepsy or IH. And the question when they queried the database was, how do these healthcare providers diagnose and treat narcolepsy and IH? What they found, two interesting things in their conclusions, that patients with a diagnosis of narcolepsy or IH constitute a very small component of the overall patient clinical cohort, very small, a fraction of a percent. And even among sleep specialists, that's only 2%, only 2%. That's significant, I think, and we'll make more of that a little bit later. So, and the other part of it was, this part that blew my mind, is that they found that 80% of the sleep specialists, I'm not talking about 80% of the patients, but 80% of the sleep specialists, those who are sleep specialists who are trained to treat sleep disorders, were not prescribing the narcolepsy-specific medications, specifically WAKIX, which is approved, and oxybates, which are approved. 80% weren't using those medications. So my thought was treatment alternatives are not recognized.
Dr. Harsh, I'm going to interrupt you for a second because we've been going for 10 minutes. Does anybody have any questions? Okay, I have a question.
Sure.
Why were those doctors not prescribing narcolepsy medications when they were sleep specialists?
That's what we need to know. So you would think that sleep specialists would be aware, but in some cases they may be aware, but they were finding success with alternative medications, with modafinil, solriamfetol, WAKIX, or not WAKIX, or some medication to address the sleepiness and cataplexy. Maybe they were comfortable with what they were doing. But my impression is, from looking at the other abstracts, is that they just don't know. They just don't know about what these new medications can do for narcolepsy with cataplexy. These are busy people. They have full clinics, and they don't always make it to the conventions, and they always look through the journal articles that they see. And many of them were trained, 10, 15, 20 years ago, just don't know that the oxybates and WAKIX can be successful in treating narcolepsy and IH. But
okay, so they would prescribe other things like maybe Dexedrine or Adderall,
exactly,
or Ritalin.
The people who were trained 25 or 30 years ago, when I first started doing research in clinical practice, the most effective treatments, most commonly used treatments, were the amphetamines and Dexedrine, right? Okay. And there's an inertia associated with that treatment strategy. This has worked best in the past, so it must be the best thing to do at the current time. So we have a lot to do to combat that, I think. But that's a kind of a stunning
Yeah, that is
piece of
stunning.
data.
Looks like Marissa has a question. Maybe she
Sure,
wants to
Marissa.
jump in.
Hi, thank you. Thank you, Dr. Hirsch. Appreciate you updating us as always. My question, you kind of just touched on it, but it's a question about data gathering. Previously, you showed a chart that showed the average length of time to get diagnosed, 5 to 10 years, which is down. It took me
Yes.
it took me 20. So I'm 42. That being said, I was diagnosed at 31. I started exhibiting symptoms at 11.
Wow.
It took me another 10 years before I received proper treatment from the time I was diagnosed. Now, when I say proper, I mean both wake and sleep. I have narcolepsy too. And I wasn't going into deep sleep at all. So my question is, I was taking Nuvigil for a long time, but it took me 10 years before I was able to get sleep medicine that worked. So before I was able to get Xywav. And a lot of that had to do with insurance and being able to keep doctors because of insurance and things like that. So getting to my question, the data point I'm curious about is how long does it take people when they get diagnosed till when they feel like they're receiving some sort of adequate treatment, if any, and if that's been collected at all? Thanks.
That's a great question. So one of the things was one abstract from Michael Thorpe, I believe, that at the conference, there was another well-recognized sleep researcher, is that his strong point was that physicians aren't fully evaluating symptom progress. They'll ask patients, how is your sleepiness? It's better? That's good. How's your cataplexy, if that's what you have? Is it better? Yes, that's good. How's your sleep at night? Is it better? If it's yes, that's good. And then they stop. So the question is, how, in my mind, and the patients that we work with, patients that are concerned to me, is how close are you to being normal? Is that, do patients with narcolepsy and IH know what normal is? A lot of them have a pretty good impression of what other people who are normal are like. And the response to that question is, in many cases, treated patients, they will say that they aren't there yet. They aren't normal. Perhaps the majority of patients, affected individuals, will say they're not there yet. It's very seldom the case. I work with an individual who will say that they are where they want to be. That may change with the orexin agonists that are coming, because the preliminary data look really, really good. So patient assessing sleepiness, some of them are able to maintain wakefulness beyond what a normal person without narcolepsy or IH can do. With the maintenance of wakefulness test, we give people an opportunity to go to sleep 5 different naps during the day. For a normal person, the average latency to sleep is someplace between 20 and 30 minutes. In some affected individuals treated with an orexin agonist, they don't go to sleep at all. I mean, it's 40 minutes is their sleep latency. So the situation may change. But right now, my impression is most patients aren't where they need to be. Most individuals aren't where they want to be with regard to treatment efficacy. What do we do? And that's the question I would like to discuss in just a little bit. So thanks for keeping me on track, Kristen. So postural orthostatic tachycardia syndrome. So I looked at, what does POTS have to do with narcolepsy and IH? But it's there. POTS is there. Some of you may be familiar with POTS, some have not. But with POTS, you have in changing position, you have a dramatic increase in heart rate. That's what's most obvious. So if you go from a sitting to a standing position, heart rate may go up to over 100. That's probably one of the most commonly used criteria. Just skyrockets and goes up, sometimes a lot higher than that. It's associated with dizziness. It's associated with fainting. It's associated with other symptoms, but it's an autonomic disorder. It's an autonomic disorder. What does that have to do with narcolepsy and IH? But in this paper, it was on IH patients, and the question is IH with POTS a distinctive subtype of IH? And we said these disorders are very heterogeneous. So what they found was that about 1 in 8 IH patients also were diagnosed with POTS. And for those that were diagnosed with POTS, we had other disorders. Ehlers-Danlos syndrome, you may not be familiar with that, but that's a connective tissue disorder. You know, where does that come from? Fibromyalgia and headaches were much more common in patients with IH and POTS. And here's the kicker. Those with IH and POTS were dramatically more likely to have side effects from amphetamine and dextroamphetamine and methylphenidate, right? Amphetamine, Ritalin, and I mean, there's a remarkably different. So this is a very significant group of patients. So IH plus POTS more likely to have these comorbid disorders and may signal increased risk of side effects. This is why we need to ask at the point of evaluation about POTS and other autonomic disorders and to follow those during treatment. So at the diagnostic evaluation during treatment management, patient burden is often not fully addressed. Comorbidities may not be evaluated or followed during treatment. The full range of treatment options may not be given consideration. So here's where I had a stopping point. Diagnosis and treatment of NT1, NT2 and IH, very challenging for the clinician. They're complex, they're heterogeneous, different from one person to the next, and they're burdensome. They're rare. I capitalize rare because that's the problem that we are dealing with. This is a rare disorder. The physicians that know about these conditions and their treatments have problems because they seldom see people with these conditions, and they don't get much training on people with these conditions. So they may not be what they need to be in the clinic setting. So discussion point. Here's where I would like to hear what you have to say. How does an affected individual ensure that their own individual NT or IH burden is understood, that their comorbidities are recognized, and that their treatment plan is optimal? What do you all do?
Do we want to take, Melissa's got a question. She's had her hand up, but after that, we should definitely go to that if you don't mind taking her question first.
Melissa.
Well, I think my question is probably going to be answered in the discussion. I just jumped ahead.
Okay. So, guys, what should we do?
I'll just say, I mean, as somebody, I'm in my mid 40s. I got diagnosed at 31. I was collapsing for 10 years. It's been a roller coaster my whole life, but I've not had a medication that has actually benefited me. But I think the one thing I want to say is, like, you just you gotta advocate for yourself and speak up and really nail down when there's something you're trying to reach or get taken seriously on. Those are my 2 cents.
Absolutely. Right. I think it's really important to be your own advocate as well. And I kind of put it together through the internet and my grandmother. and I was able to know I had narcolepsy within a few months of onsetting, and I just had to go. I had to go to the doctor and tell them this is what I have. And then I found out my mom's health insurance excluded all sleeping disorders. So it took me a while to get on my dad's, but I was able to go in there with pinpoint precision, and I would say by the summer I was going to probably the best sleep doctor in my area at the time, Dr. Philip M. Becker.
Yes,
Was in Dallas.
yes.
So he treated me for 17 years, and he was very, he was very intentional with what he prescribed. It took him a long time to be convinced that my cataplexy was severe enough for Xyrem. He was so confident, by the time I was pregnant, to have me on my full dose, which is that exceeds the maximum FDA approved at 4 grams 3 times a night. But
Wow.
the cataplexy warrants it. So that I'm now a patient of Dr. Morse, and I think you have to expect certain level of care from your doctor. Yeah, you are going to them, and I go to one of the very best sleep doctors in the world, in my opinion. She still reminds me that we're partners in this. Your life experience does matter in this, but that means enough for me to fly out of state to see you, because that level of care is hard to find.
Do we
He's
want to
awesome,
jump
Mrs.
to,
Sorry,
or-
yeah.
sorry,
I'm
John.
done. Thanks.
I was just gonna say Melissa's got her hand up. She wanted to jump in, and then Megan after that.
Yeah, I'll kind of follow up with the question that I had. So say I have a bunch of like things going on that I don't know if they're like one of those comorbidities, and I'm not sure what's going on. Like, what would be the best way to approach that? Like, would it be talk to your sleep doctor? Like, talk to another doctor? Like, what would be like optimal to try to figure out like if that is correlated like with your sleep disorder?
That's a great question. And so here's what I suggest for all patients, for all conditions, but for narcolepsy and IH, is that you use a diary, and that you write down before you go see your physician, and for yourself following, you want to list the symptoms that you're experiencing, okay, and how severe they are, and you want to list the burden that's created for you, okay, so you have a little sheet. Here are symptoms, here are burdens, and the comorbidities that are associated with them, and your notes about treatment, efficacy, and safety. What I'm arguing for, and this has been mentioned several times before, is we all have to be advocates when we go to the doctor's office. And more than that, we all need to be, especially with rare disorders, our own case managers. And to be our own case managers, we need to stay on top of what's important. What are the symptoms and their severity? What burden is this creating for me, right? What are the comorbidities that I have? What am I experiencing with regard to my health and well-being? And how am I doing with treatment, right? Am I functioning at a normal level with whatever your perception of normal is? Am I there yet? And when you go see your physician, you want to have that document. I would advise having that document with you and sharing that with them. I mean, write it all down and give him or her a copy of it. Okay. It's complex and heterogeneous disorders. There are so many different facets, and patients differ from one to the next. And these are rare disorders, and physicians are really caretakers are really challenged to keep track of everything that's going on in your life. It's very challenging. So you can help them by being your own case manager, your own nurse, if you want, and by being your own advocate. Say, if they do the assessment and it doesn't address all the issues, you can say, I don't think I'm there yet. I don't think I'm where I want to be. I don't think I'm where I should be. And you have a discussion about, what are the treatment strategies? What are the new treatment strategies? What are the promises of these different approaches? Okay. So, and another point that's been raised, I mean, Anne-Marie is wonderful. She's just delightful. But you ask yourself, is my healthcare provider doing the kind of job that I think they should be doing? Right? These are rare disorders. And if you're going to a healthcare provider that's only seen one or two in their whole career, you ask yourself, are they, and they may be, but you ask, are they doing the best that can be done? You can ask them, for example, I'd like to get a second opinion on my diagnosis. Do I have IH or narcolepsy type 2? Or do I really have, maybe I have cataplexy, right? Which is another challenge to identify. And pick your physicians carefully. All physicians, in my experience that I've worked with, want to do a good job. Not all of them are prepared to do a good job with a rare disorder. And they will tell you, it'll be right up front, should be right up front and say that their experience may be limited. And I say, yeah, it's a good idea to travel to, where is Anne-Marie? In Pennsylvania now. You travel to Pennsylvania to see her. That's, it's worth it. When I had the good fortune of being in Mississippi, I had a colleague that was an outstanding physician, board certified in 3 different areas. And both of us were invested in the hypersomnias, the sleepy people. And we had people coming from all over the South, from Florida to Texas, New Mexico.
Yes.
To come into our clinic.
I mean, I've had I haven't had very good luck with doctors since Dr. Philip Becker retired. I mean, the best luck I really had was Dr. Swick in 2000. Well, in 2000, I started seeing him in 2016, and then he retired to work for Takeda. Yeah. And so unfortunately the viewer that asked the doctor's name that I went to in Dallas, his name is Philip Becker, but he's unfortunately retired. I mean, there are some doctors in the Dallas area that we've been trying to work on, but I can put on on the group page later.
Yeah.
Dr. March, we're going to move on with your speaking right now, because I'm sure you have more to tell us. And then we'll hear from Phoebe and Melissa during your next break. And I know we're a little bit past 7.
Okay, good. So what's next? So focusing mostly on narcolepsy type 1, narcolepsy with cataplexy, the PINTAD, and the tendency for the healthcare provider to look at the symptoms and then look at the features of a disorder, one of these disorders, look at the symptoms that you present and try to match. match the symptoms with the symptoms associated with the disorder. And that's pretty clear that with narcolepsy type 1 and type 2, we have these symptoms that we go by. But IH is a different story and a lot to talk about, but I know I will keep it brief. But it's like we have a long way to go with idiopathic hypersomnia. We made great progress with narcolepsy, type 1 narcolepsy. We're not close yet with IH. IH is, we associate IH with long sleep time. That's not always the case. Some individuals will sleep 14, 16, 18 hours a day, right? And they may wake up from that extended sleep and be okay. They're not that sleepy, right? Some will sleep only for 8 to 10 hours, and be extremely sleepy. So we have excessive sleepiness, we have long sleep time, sometimes, maybe half the time. We have sleep inertia to the point that people report waking up in the morning, if they can wake up in the morning after 2 or 3 alarm clocks or someone shakes them or something happens, and they will drop things, they'll run into the wall, right? They sleep, it's called sleep drunkenness. That's a sometimes feature, a feature of IH. Unrefreshing sleep is often associated with idiopathic hypersomnia, not always. It's heterogeneous, not always. Disturbed sleep is, many of the people that I see with IH, they turn out the lights to go to bed, to put their head on the pillow, and they wake up the next morning, or they try to wake up the next morning, they're gone. But that's not always the case. So it's a very heterogeneous condition. And there's some debate about whether IH and narcolepsy type 2 are the same or not, because they're very close in terms of symptoms. We have, with narcolepsy type 1, we have hypocretin, orexin hypocretin as a biomarker. We have no biomarkers for hypersomnia. We don't know about the underlying mechanisms. We have hypotheses and theories, but we don't know what the underlying mechanisms are for sure. A limited study of burden. We know the burden is high. And my argument tonight is that we should ask ourselves, what is the burden I am experiencing with the condition that I have? And that's something that should be shared with your healthcare provider, and the healthcare provider and you should follow that during treatment to be sure that everything is being done to reduce that burden. Lots of comorbidities and different types of IH phenotypes, different types. And the research on that's ongoing. It's complicated. And I can't even keep track of all the new things that are associated with it. I mean, Ehlers-Danlos is just really remarkably interesting. And with IH, if you may get some benefit from modafinil or armodafinil, many people don't. You may get some benefit from WAKIX or some of the other medications, many don't. Dexedrine, if you take enough amphetamine, that will get you going, right? But the tolerance develops and side effects are prohibitive in most people's minds. So IH is another disorder where we just haven't made satisfactory progress yet. People are trying, no question about it. Now, another thing I wanted to mention in the time that we have is that the comorbidities, as you say, what are if I need to keep track of the comorbidities, I want to share my comorbidities. What are the comorbidities that are often associated with these conditions? For sleep, you have sleep apnea, you have periodic limb movement disorder, you have REM sleep behavior disorder, which is higher in IH and narcolepsy. Mood, on the graph on the right, a variety of mood disorders that are elevated in association with these conditions. Social anxiety, major depressive disorder, panic disorder, PTSD, agoraphobia, even bipolar disorder, right? So any of those conditions, you want to recognize those as comorbidities. Any mood disorder, even if it's not here, and you have a mood disorder, a mood problem, dysthymia, then that's worth recognizing and sharing. Neurodevelopmental disorder, most commonly ADHD, which we're all familiar with. Cardiovascular disorders, heart attack, stroke, the major ones. Neurological disorders are often a problem. And the autonomic disorders. What are the autonomic disorders? These are, in my experience, are often missed. This is dysregulation of the heart rate and dysregulation of blood pressure levels. That is subtle. You say, oh, my heart rate is up or my heart rate is way down, but I recover from that. That's not a problem. That's a comorbid disorder, possibly. Digestive conditions, managing the breakdown of food and nutrient absorption. That is associated with these disorders. Internal temperature. Several people that I've worked with will report, oh, I have hot flashes, or I get cold, right? And it's not a huge thing, but it's there. It's there, and it's worth tracking, keeping track of during evaluation and during treatment. And another one, sweating. It's like something that we tolerate, and we don't really think about it, but it's a comorbidity. It can be a comorbidity that we want to recognize, keep track of. And bladder function, frequency and urgency. So those are some of the autonomic conditions. And in the upper table, I have a section for all these sleep disorders by narcolepsy, type 1, type 2, and idiopathic hypersomnia. I'm interested in these comorbidities because they may be different across these disorders. And if they are different across these disorders, that gives us information that these disorders are distinctive or alike, right? We don't know why we have these comorbidities. It may be because, a comorbidity may be because, well, deconditioned, we don't get enough exercise. It may be because we have a chronic illness, or it may be part of the mechanism itself that's producing the sleepiness, which is what's driving all this. So what else do I got? Oh, okay. So a little bit about the clinical trials. Most of you know, you are very aware group. We know that about orexin and sleep-wake regulation. I like to think of as, with traditional treatments of sleepiness, we try to tap into the norepinephrine, dopamine, serotonin, and histamine systems. So we try to activate the cells that produce those neurotransmitters. We're treating symptoms with dopamine, serotonin, histamine, and norepinephrine activation. Orexin is like an orchestra leader because the function, one of the functions, and there are many, of the orexin neurons is to activate neurons in the areas that produce these neurotransmitters. So when orexin is gone, we don't have the activation of all these different arousal centers, and we have excessive sleepiness, and we have a likelihood of cataplexy. So when we don't have orexin cells, we have a problem maintaining alertness, and we have a problem with increased likelihood of problem with cataplexy. So clinical trials. Alkermes, Takeda has finished their phase 3 trial. Alkermes is starting a phase 3 trial. Centessa is starting a phase 3 trial. There are 6 to 8 different companies that have molecules that are considered orexin agonists. They're different molecules. Why is that important? Because Takeda already knows that with one of their molecules, you would get liver dysfunction, and we get urinary frequency and urgency. Jazz knows that with their molecule that they tried, they got visual problems. Where did those come from? Visual disturbances, right? So these molecules are all different molecules. Takeda has 5 or 6 different molecules. There are 8 different companies that have molecules. And this research is likely to go on for another 5 years, 10 years until we get the optimum treatment for us, right? The optimum orexin agonist for us, if that's the path that we want to go on. So yeah, so this orexin molecule activates orexin 2 receptors, which is the key receptor for sleepiness and cataplexy. And in the research that we have available now, the effects can be astounding. With traditional medications, we have residual sleepiness almost always. We have residual cataplexy almost always. With the right orexin 2 receptor agonist, we may not have any cataplexy. We may not have any sleepiness at all. And our management strategy is to maintain a proper dose that will give us the proper level of alertness without interfering with sleep at night. Okay. WAKIX pitolisant is a histaminergic agent. This is interesting. Histamine has some of the same effects that orexin does. That the histamine activates those arousal centers that I was just talking about. They're similar. There's not much attention to that. So I'm interested in what's going to happen with this new clinical trial from Harmony with WAKIX. Dosage range for WAKIX now is 17.8 to 35.6 milligrams with a new formulation. The dose, the maximum tablet is 60 milligrams. 60 milligrams. It's not quite twice, but it's almost twice the dose of the current formulation. And Harmony I feel that should increase efficacy. And with their formulation, which promotes more rapid absorption into the gut, side effects should not be as much of an issue, but we'll see. So, we are going to do a trial with alkermes, with the orexin agonist. The phase 2 data really look good. We're going to do a phase 3 trial for pitolisant. I'm anxious to see that data. The phase 2 data look pretty good. I'm developing optimism that, for those patients who can't or don't want to try an orexin agonist among the new products, that WAKIX may be okay, maybe good. So that both trials involve patients with NT1, cataplexy, NT2, no cataplexy, and idiopathic hypersomnia. So some of you may be interested in one of those trials. If you are, I have my email address there. And how am I doing, Kristen?
You're muted, Kristen.
You're muted, Kristen.
You've got 8 minutes. We've got 8 minutes.
Good,
Kristen.
Happy to
Dr.
answer
Hirsch, you're
any
doing
questions.
great. Do you have more information for us, or should we switch to questions?
Let's switch to questions. Yep.
Okay,
Can
Phoebe, you want to go first?
Okay.
Mine was more of a comment. I mean, I can keep it quick. We talked about how to advocate for yourself and ensure the best outcome for yourself in doctor's appointments. I just wanted to share with the group something that's really worked for me. Like this past year, I actually started voice recording my doctor's appointments. And, I always ask permission beforehand if they're comfortable with that. I have a handheld recorder, and I also use, if you have an iPhone, there's a voice recording app that's built in. So what I do, I'll record the session and then actually copy the transcript, and I put it into ChatGPT and have ChatGPT give me an outline of, action steps, what was discussed. And that's been a game changer to help me stay organized. So yeah, I just want to share that with the group.
That's
Thanks, Phoebe.
excellent, Phoebe. That's
You're welcome.
really great idea.
Thanks.
If you guys have a question, why don't you raise your hand and Saul can field the questions.
I was gonna jump in because Ryan had a question a while ago in the chat. It is as a person who has or was DX'd with idiopathic hypersomnia at 41 and been on treatment with modafinil briefly and Nuvigil or modafinil for 5 years, I would say I'm just miserable. How does WAKIX and other meds compare in clinical trials to our modafinil?
They're not what we want them to be, but there's a lot of individual differences. It's a heterogeneous disorders, they're complex. So I'm not surprised that he hasn't had an optimal outcome with modafinil or armodafinil. Those can be very useful, but many patients, it doesn't. With those medications, there needs to be something else in addition. If there's cataplexy, of course, there has to be something else to control the cataplexy. But it often takes combination therapy. So for this person, I would recommend considering just now that a combination therapy might be needed to improve their circumstance. And that actually might include amphetamine or dexedrine, right? It might be, one of the heterocyclic derivatives of amphetamine. So in my experience, patients would come and say, I do well most of the time, but in the afternoon, driving home is a problem. They get really sleepy driving. And so we look for something that we can use that's low dose, has short half-life to get them through that critical period of getting home. And sometimes it was a low dose of amphetamine, low dexedrine actually, to get them there.
All right. There's another question. Do these medications help the patient go into deep sleep, or are there more meds to keep us awake? And then Casey, we'll try to get you into.
So a good question about deep sleep. Here's the issue with the orexin agonists. What are the effects on sleep architecture? We know that it may, if it's a late day dose, then it may result in insomnia, right? Difficulty going to sleep. But an early day dose, is it going to have any effect on sleep architecture? Is it going to increase slow wave sleep? Is it going to decrease slow wave sleep? Is it going to have an effect on REM sleep? I'm waiting for that data. Really curious to see what that data look like. The oxybates, with some polysomnographs that I've seen, it looks like we have more deep sleep in some cases with the oxybates. It reduces sleep disturbance, which is there in some cases. It increases slow wave sleep. The other wake promoting therapeutics I'm familiar with. If you take, modafinil or modafinil, oddly, don't always have, as I had people who were taking modafinil or modafinil at night and not having trouble going to sleep, right, and sleeping reasonably well. In fact, I used that as a therapeutic option for some disorders. But yeah, the data on sleep architecture varies with the product, and it varies with the individual.
It looks like Casey might have jumped out. So Christy, if you want to jump in with your question.
Yes, Dr. Harsh, is there a known connection between orexin and autonomic issues? And do any of these new orexin agonists have potential to treat comorbid conditions, including but not limited to the autonomic issues that you've mentioned?
So yes, orexin is one of the many, the orexin neurons are one of the many neurons that are in the hypothalamus, right? And I think at times about in narcolepsy and idiopathic hypersomnia as hypothalamic disorders. One of the functions of the hypothalamus is mood control and maintaining autonomic stability. And from that perspective, it's not that surprising that we have orthostatic hypertension and POTS and other autonomic dysregulation in association with narcolepsy and idiopathic hypersomnia, because the problem may be the same in the hypothalamus, may be a hypothalamic disorder. And when you have problems with one of those neurons are those collection of neurons are communicating with each other all the time. You have a problem with one, you're likely to have problems with the other, right? So that's the way that I put that together.
Casey, do you want to jump in? We're going to go maybe a few minutes later if everybody, or if that's okay, but
Sure.
try to get Casey in here.
Yeah, my question real quick is, what would you say the likelihood that we're still going to have a combined therapy with an orexin agonist and something like a sodium oxybate, as far as like to be able to continue to not have the fragmented sleep? Because from what I understand, at least the current agonists that are in trials are somewhat shorter lasting, more of like an instant release. So unless you were to take a later dose that would increase your wakefulness, it doesn't sound like you would have the effect of the orexin to stabilize that sleep architecture. So it kind of sounds like we would still be managing daytime much better with the orexin agonist, but for those with the fragmented sleep, still needing the oxybates. What do you think about that?
So I think I already mentioned that Alkermes just purchased Avidel, who makes once nightly oxybate, right? And
Yeah,
so,
Lumryz. I'm actually on Lumryz, so
Lumryz, yeah. So speculation is that they're anticipating that the agonist, the orexin agonist, will do potentially a great job in improving daytime alertness, but may have a problem because it increases insomnia, may disrupt, I'm not saying it does, it may disrupt sleep architecture, and then there's a need for something to address that. And Lumryz and oxybate therapy can do that. So I think a lot of the people that I talk to, a lot of the clinical investigators are saying that there may be a good possibility that an orexin agonist might work as a monotherapy. There's a good possibility to be a monotherapy, just one therapy, if you get the dose timing down correctly. But there's almost certainly going to be some patients who need adjunctive therapy with an oxybate. So your question is right on.
okay.
We need to know the effects on sleep. I don't know the effects on sleep except the insomnia effects.
Great talk, Dr. Harsh. You
Thank
hit
you.
on a lot of really good stuff.
Thank you so
Kristen, do you
much.
want to finish up the?
Yeah, Dr. Harsh, thank you so much for this information. It was really informative and I learned a lot and I'm hoping that everyone else learned a lot. So if you guys want the recording or the AI notes, just email me and I'll forward those over to you. But thank you again, Dr. Harsh, and we hope that you have a great night.
Hey, my pleasure.
Thank you, Dr. Hirsch.
Great to visit
Thank
with you all.
you.
Thank you so much.
Thank you. Good night.
Night.